Good evening, everyone. My name is Deborah Hilbasell. I will be doing your case list construction tonight. And I think you're the same three who were on when Dan Green did the previous one with case list construction, because I kind of looked at to see what he did and what he covered. And then hopefully I will cover some additional things. But let's just go ahead and do a little bit of our homework first. All right, so with how to participate today, all of you guys, if you were on the previous one, know how to do this, but let me just quickly walk through this. You've got this little orange arrow up in the top that can open and close your panel. You've also, looks like all of you guys are on using your mic and speaker from your computer, so there's nothing special you need to do there. But if for some reason you got disconnected, you lost your audio, you could actually go back and click on use telephone. You'll get a phone number, an access code, and a PIN number, and you can rejoin the conference. You won't be submitting questions because you'll be able to ask questions to me as we go along. But if you do have a specific question, feel free to raise your hand. We have a small group. I'm going to try to do what Dan did in that unmute all of you so we have more of a dialogue than me lecturing and then you guys raising your hand. But if it for some reason that doesn't work, please raise your hand. I'll pay attention to that and I will come back to you. All right, so what do we kind of need to know here? So let me just go over a little bit of stuff first and then well, actually, let me go ahead and see if I can unmute everybody right now. Let me try to get George. It says you're self-muted.
Hi,
Okay,
can you
there
hear
you
me?
are. You there? Yeah, I can hear you now, George. Let me see if I can get Richie on also, okay? Richie, you're self-muted also. So make your little microphone that's got the green circle, make it green.
Can you hear me?
There you go. Yep, I can hear you now. All right, so Zishan, I guess is how we say the next one. Are you there, Zishan?
I am, thank you.
Okay, perfect. Okay, good. So it's just the three of us. Weren't all three of you on the same one with Dan Green?
Yes.
Yes, I think so.
Yeah, I think so, because I think that when I just kind of, like I said, I went back and I looked at to see what he covered. So I typed up some stuff, a couple of things that I think are important with regards to certain dates and what some of the things that ABOG says in the bulletin that I just want to go over again to make sure everybody's clear. And then I actually thought about, because I've already done quite a few even case list reviews for this year. So I thought, all right, so what are some of the questions that the people that I've already sent the case list reviews are coming back and asking me? So where is some of the confusion? And we'll go over that too. So because it's just three of you and me, let's just make this like a roundtable conversation. And if you want to jump in, interrupt me, ask a question, please do. All right, so we'll be real informal here. All right, so I'm going to kind of close that here. Just, you guys know this, but you know your first deadline for submission of case list to ABOG is August 16th, but you can actually even wait until August 31st. But of course, if you do that, they want more money, so it'll be an extra $395. All right, so this is one of the other things too. And again, you guys are here on this lecture, so you're not going to be the one who gets in trouble for this, but you'd be surprised the candidates who submit case list reviews that have just incomplete information. They forget things aren't filled out, they put things in all different categories, and I'm sometimes kind of surprised and really glad they submitted it for review. But obviously, if you have a carelessly prepared or incomplete case list, that in itself can be a reason for disapproval for the exam. A poorly prepared case list can also contribute to failure to pass the exam. And then they just talk about if you don't give the right information, you don't have enough patience, it's incompletely or inadequately prepared, etc., again, could be disqualify you from admission to the certifying exam. So here's some of the things I think that can be a little bit, some of it's confusing. You guys know who you're going to, the time period, of course, it's from last July 1st till the June 30th, and any hospital, surgery center, etc., that you either admitted or saw, I don't mean to say admitted, but did like outpatient surgery, etc., they all have to be listed. But this was a question I had actually this year. I had one of the candidates say, hey, if I just did a consultation for somebody in the hospital, am I supposed to list that patient? And they do clearly say in the bulletin, candidates may not list patients for whom they've only provided a consultation. What I think was also interesting is they talk a lot about the COVID patients, because this last year or so was a different year for everyone, where people were called to do stuff that we normally didn't do. I mean, I know a friend of mine who's a urologist. He said, you know what, we didn't do any urology surgery. We were taking care of COVID patients. I hadn't done intubation since residency, and here I am, a 50-year-old guy intubating COVID patients. So you can list COVID patients if you were primarily responsible for their care. But if they were your patient, you admitted them, and then you basically turned them over to the medical service, you do not have to list that patient if that was the only reason for their admission. This is the other big one that I think is a problem here. In the case of partnership or group practice, which this really applies mostly to the obstetrics, but maybe could a little bit with the GYN, the patients listed should be those managed by the candidate. But if some portion of the care was provided by a partner, that care should be indicated on the case list. Now, to me, this is really subject to interpretation. And I think if there's, and I have this typed up on one of the other slides too, but I'm going to go over it now. The whole case list construction. All right, we know the time frame you're supposed to put the patients in. We pretty much know, we think, which patients are supposed to be on it. But from then, it really is pretty subject to interpretation. And we as Exam Pro faculty, and I've been doing this for years, I've reviewed thousands of case lists. We follow what I think is a nice logical example that Dr. Shamroth kind of set like, this is how I think a case list should look. Now, within examiners, like Dan Green and I might say, oh, I don't, like he said something to you guys, yeah, I don't think it's a big deal if you put an exclamation mark or you capitalize stuff. Alvin thinks that you shouldn't do that. So there will be things within examiners that we may recommend that you do something different. But think about it. Ultimately, it's your case list. And if you're like, I don't really like the way Dan Green said to do that, or I don't really like the way Debbie said to do that, please use your judgment. We truly are giving you guidance, and also saying, you know, in reviewing, all of us have done thousands of case lists, I'm sure. But so this is what was kind of the standard. And if you want to vary from that some, so be it, because unless it's a black and white, do not do this, there really is a lot of interpretation. Okay, so that's, I guess, you know what the main thing is? And I do agree with Dan on this. You need to make it as easier for your examiner to look at your case list, see what you did and why, and not make it really cluttered and confusing. Okay, so you know what to do about the OB case list. You know, minimum of 15, only 2 per category count. But I'm still surprised how many people will put down patients, and I'll be like, okay, this patient shouldn't be on the case list. This is a normal, uncomplicated OB patient. And I'll say, please refer back to the bulletin, whatever page this is on. I can't remember right now. And look at that. I said, this patient shouldn't be listed. It used to be you had to just give them the number of uncomplicated OB patients you did? You guys don't even do that anymore, do you?
No.
On your case
I
list?
don't think so.
Yeah, no, I mean, I don't think so either. There used to actually be a space on the first page of the case list when you started it. Up at the very top, you were to put the number of uncomplicated OB patients that you delivered. So anybody who fell into this category and fit, you didn't list them specifically, but you numbered them. Well, then they could figure out like what your primary C-section rate was, what your total C-section rate was. Now, I mean, they really don't have a clue what your C-section rate is because all they know, you know what I mean, is none of these uncomplicated patients are even delivered. But anyway, just know if your patients meet any of these criteria, and I'm not going to go through and read them all. You guys know where this is in the bulletin and what it is. Don't list them. Otherwise, it looks to the examiner like you didn't read the practice bulletin or you didn't read the bulletin very well, and it looks sloppy, and I think it reflects poorly on the candidate. All right, so if you're a backup for a midwife group, don't list the delivery unless you did it. But here's where again it gets goofy. So if you are if you're teaching faculty, all resident cases for which the candidate had responsibility must be included. So if you were on call and 17 deliveries got done while you were on call for the residents, all of those cases have to be delivered, even though you didn't do the delivery, but you were the responsible attending. Same thing as if go ahead.
Yeah, so look, going off the butts, if you had 17 deliveries in a night, or in the previous slide where you said 15 inductions, only 2 count, the other 13, we still list them under the inductions or on the other?
You list them under the inductions. So you list them under the proper category, but let me go back here. You list them under the proper category. So when I say you can only count 2. So for instance, if you have 12 inductions, they're going to be 12 under the induction category, but only 2 of them are going to count toward that minimum of 15 OB cases.
Some of the strategies that we were taught by Dr. Shamworth about capitalizing, exclamation points, and really trying to think about the questions they're going to ask. Should we only do that for the 2 that count and the other 12 just list them? That way we're not spending so much time trying to figure out all the possible questions or style of inputting the cases for 12 inductions, rather just focusing on the 2 that we would want to be asked questions about as the first 2.
No, I don't think so, because it doesn't matter which ones you want to get asked questions about. The examiners are going to pick whatever they want. Do you see what they're saying with this is they're saying in order to even sit for the certifying exam, you have to give us at least 15 obstetrical cases. We're going to give you categories. You need to list every single patient you delivered over the past year. But if all you did, let's say the only kind of deliveries that you did were inductions and C-sections, and that's the only 2 categories you filled out, it wouldn't matter if you had 300 patients. Only 4 of them would count because you only filled out 2 categories.
Got it.
Does that make that part makes sense? Now, if you said, should we kind of, if you're like, but I really only want to talk about the first 2 inductions, I don't think the examiners care what you want to talk about. I think they're going to look at the case list and they're going to choose what they want to ask you questions about.
Okay.
So with regards to capitalizing certain things, most the times where I've really seen that is when somebody has had an unexpected outcome, like maybe they did a hysterectomy and the pathology came back invasive cervical cancer, and they were doing a hysterectomy for what they thought was benign leiomyomatous uterus. So that was a totally unexpected finding. I've seen stuff like that, and people put the pathology in capitals and put all these explanation marks. I'm kind of the thought, why do that? Yeah, it was unexpected, but just list it like you're going to list everything else, and know the examiner's mostly is going to probably ask you about that one. Dan Green says, you know what? I don't have a problem if you want to capitalize that and put an exclamation mark, because you're telling the examiner, boy, this one shocked me. So if you want to ask me about it, go for it. There is no right or wrong. Does that make sense?
That's right.
So, all right, so that's kind of that's where I'm saying where so much of this is subject to interpretation. Okay, so then I put this in capital too, or in bold. If the candidate cares for the patient in the hospital, but does not deliver the patient, the information on the delivery in the infant shouldn't be listed. For example, somebody comes in with preterm labor without delivery. You do not list her delivery info unless she comes back in. Like, let's say you sent her home, she came back in later, 5 weeks later, and you delivered her. But if she comes in 5 weeks later and your partner delivered her, then you don't even list the delivery information. But now let's back up. But how does that work with, but you're supposed to, if one of your partners did part of the care of your patient, you're supposed to list it. Do you see what I'm saying? You can overthink this, because that's why I put, again, this can be confusing, because if you said, well, she was my patient and I am in a group practice and she came back in a month later and my partner did her delivery. Well, they're still saying don't do the delivery, but then they say if your partner did any of the care, list it. Do you see what I'm saying?
Right.
Are you guys following me? I'm just showing you how I'm going to give you different examples, but with the OB case list, and I've got some examples on what do you do when the MFM does all this stuff. So we'll get to those in a minute. All right, and then it says if you can't find 15 cases, you can go to 18 months, etc. Then this talks about the if you can't make your minimum, contact them, and they'll figure out what else to do because of the COVID pandemic. And then again, this is where I talk about, remember how much of this truly depends on your very best judgment calls and kind of how to interpret the bulletin. All right, the GYN case list. Yeah, go ahead.
For the OB case list, I work in a rural hospital, which is not even a level 1 facility. And so when it comes with, can't deliver anyone less than 35. So I am, transferring them to the higher level over an hour and a half away, which means,
right.
So I'm trying to think how many times I had a 34, 33 weeker. Maybe it's once, because I transfer them. Does that look bad? How's it possible that I had no preterm deliveries at all?
No, it doesn't. No, because do you have them listed as an admission and a transfer?
Well, I haven't done it yet. That's one of the reasons I wanted to ask right now. What's the best way to assess that?
Yeah, so if she came in preterm labor, I would list her under I wouldn't even put her under the preterm labor without delivery, because I would put her, because you didn't just manage her and send her home. I would put that person under the preterm delivery category, and I would put she comes in, she's in preterm labor, and then what do? You maybe started GBS prophylaxis, betamethasone, all that kind of stuff, and then your treatment was to transfer her to a tertiary level hospital.
Got it.
And then that looks perfect. And then if they ask you, you just explain, I'm in a rural community, and our hospital, we don't deliver anyone who's less than 35 weeks. Easy.
Perfect.
All right, good deal. All right, so in the GYN case list, here's a couple of, they talk about all the same things about, minimum of cases, blah, blah, blah. And you should have a pre-op diagnosis. Everybody has that. But here's where I can't tell you how many times people don't do this. They don't list the size of the ovarian cyst or the neoplasm. And it says this right in the bulletin, it must be recorded. So you can, a lot of times I'll put, right, acute pelvic pain, ultrasound, right ovarian mass. Okay, so I'll be like, okay, how many centimeters was it? Was it simple? Was it complex? And they do want to know that. All right, again, let's look at this next one under here that I talk about. Treatment should include all surgical procedures. All right, we get that because it's our GYN case list, as well as primary non-surgical therapy. So that can be a little bit confusing. So you're like, wait a minute. All right, so I get it. So if I admit somebody with PID, I'm going to put in there, IV antibiotics or, interventional radiology to drain a pelvic abscess or something like that. But what do you mean the primary non-surgical therapy? Like what I do as part of to get to my pre-op diagnosis to do the hysterectomy? Don't I put my endometrial biopsy and failed medical therapy all in my pre-op diagnosis, like of how I got there? So again, I think it can be confusing. The way I interpret this is when you look at your GYN case list, think about that first column as everything you did to get her to the point that your treatment is going to be your hysterectomy. So let's say you have a 47-year-old with 14-week size leiomyomatous uterus and she has bulk symptoms and abnormal bleeding. Well, then you could list, either abnormal uterine bleeding or AUB, symptomatic leiomyomatous uterus, or capital U, capital S, 14-week size leiomyomatous uterus. She's 47, EMB benign, declined medical therapy or failed medical therapy. To me, that would all be part of your pre-op diagnosis, not your treatment. Treatment would be like what you did once you put her in the hospital. So maybe she was hemorrhaged and her hemoglobin was 5.2. All right, so then, in the treatment column would be, 2 units packed red blood cells, then LAVH, or you know what I'm saying, whatever. But it's not, sometimes candidates will put in the treatment column, trial of oral contraceptive pills, all this kind of stuff, where it looks like they're trying to do an office case list. And just like this, think about this as your surgery case list, or this person's getting admitted to the hospital. So what did I do that made me then admit her? And then once she's in the hospital, you're going to list whatever primary non-surgical therapy you did as well as surgical therapy. Does that kind of make more sense?
Yes.
Yes,
I
no?
have a question
Okay.
in that regard.
Mhm.
I have a patient that I ended up doing a hysterectomy, but I did a operative hysteroscopy myomectomy, I believe it was like in March, for submucosal leiomyoma, and she was fine, but then she came back with bleeding, and then I ended up doing the hysterectomy after July 1st. So in this case, I count this case, of course, as the hysterectomy, but the operative myomectomy, the hysteroscopic myomectomy, should be on the first column, right, rather than the treatment, because the treatment for that particular case was hysterectomy.
Okay, so but the hysterectomy was done after July 1st, right? So you wouldn't even include her. Okay, so if
no, but like July 1st last year.
Oh, July 1st last. Okay, I got
Yeah,
you. So so the hysteroscopy myomectomy was done prior to your collection of cases.
correct. Yes.
Okay, yes, then that's how I would list it. Yep, only because of the dating purposes. I would
Right.
list in the pre-op diagnosis, status post, hysteroscopy, blah, 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 and then put, recurrent abnormal bleeding and what you did, and then the hysterectomy. If
Okay.
they had both been done within, because some of you guys might have this where you have somebody who had 2 GYN procedures in the same 12 months. Let's say you had done both of them within that 12-week time or 12 year, probably feels like 12 years, doesn't it? 12-month time span. You would list in the pre-op diagnosis whatever. I tell people to group it, like list 2 or 3 lines. Then in the treatment, line that up with your hysteroscopic myomectomy, then line that up with the pathology, etc. Then the same patient, then leave a space, go back to the pre-op diagnosis, and then you could put, recurrent AUB, then you did your, TAH, then you have your pathology for that, etc. So it shows it's all within the same person, but you're dividing it to 2 different things. Does that kind of make sense?
Yes, it does.
But the way you did it, because it was outside of that, that's how I would list it. All right, uterine
Okay.
weight in grams. Most people do that, but you'd be surprised how many people do not put the weight of the uterus. And why is that important? It gives the examiner a much better grasp of the size and the pathology. Do any of you guys know how much in a normal reproductive age woman, how much should a uterus weigh? They might ask you that. 60 grams, 60. Maybe 80 is up to upper limits of normal, okay? So 60 grams, maybe up to 80. So if you just say 60 to 80 grams, that's a normal uterus. In a postmenopausal women, those little things can be tiny. They can be, 20 to 40 grams. So if we know 60 to 80 is normal, so somebody who has a 742 gram uterus, it gives the examiner a much better gauge. Like if you had abnormal bleeding, leiomyoma, blah, 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 and the uterus weighed 102 grams and there was 1 2-centimeter subserosal myoma, they're going to think, really? This needed to be a hysterectomy and you're calling it for a myoma versus somebody with 1,000-gram uterus. So that's why they want the weight. All right,
Okay.
and then they do say for cases that you don't have a histologic diagnosis, you don't have tissue, you should list your final clinical diagnosis. So for instance, say you had a patient with chronic pelvic pain and you went in and you did, you're thinking you're going to find endometriosis. And let's just say let's say you found both. Let's say you saw some endometriosis, but also a lot of pelvic adhesions. So your treatment would have been, and let's say you didn't biopsy anything, your treatment would have been lysis of adhesions and ablation of endometriosis. Your pathology, you'd think you would just put none, right? Well, no, what they would want you to say is extensive pelvic adhesions and peritoneal endometriosis implants. Because you don't have a histologic diagnosis, tell them what your clinical diagnosis was. Does that make sense?
Okay.
All right, so that's in the bulletin also. All right, and then the office case list, the good thing about this, of course, is you get to pick what you want, so don't pick something you don't want to talk about, that's for sure. There's enough stuff we don't want to talk about, at least that you're forced to put down because you have to, because you admitted them. And again, we already talked about the COVID patients, and the one thing they do say, because some of the people were just pulled in. It was all hands on deck last year. And let's pray to God with this Delta variant, we don't see this again. But if you were the primary care for a man, just because that's how crazy your hospital got, you don't have to list any men that you admitted for COVID. And again, unless you primarily manage them, you don't have to list them. All right, so the office case list, what else did I want to, abbreviations. If you look at there's like 3 pages of what ABOG says, these are acceptable abbreviations. And I would definitely encourage you to use abbreviations where appropriate. It again makes it less wordy and easier for the examiner to look and see what you did. So use abbreviations where appropriate. Now, believe it or not, ABOG on their thing still has PIH listed. Do not use PIH. I mean, sometimes I'm stunned at how behind the times. I mean, the case list that they had, you know how we call it late term and post term now for, 41 weeks and greater. Well, they, until last year, they still were calling it post dates. And what did they call it? Post dates and some, I mean, they were using terms that we consider antiquated and you're not supposed to use anymore. So because I actually just reviewed a case list, I didn't even know ABOG had this, but I just reviewed this candidate's case list. And throughout, she kept putting PIH, 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 and I'm dictating my case list review, and I'm like, do not do PIH, put GTHTN, put preeclampsia without severe. So she actually sent me an email back, because whenever I sent, I said, email me with any questions. And she said, I am so frustrated with this. She goes, I never used the term PIH, but I looked through ABOG's acceptable abbreviations and I saw that's what they had listed. So she goes, I went through my whole case list and changed everything to PIH. And you're telling me, don't do PIH. And I said, well, I can't help for what ABOG does, but undo it and use the proper terminology. I've also seen really odd abbreviations. So what ABOG says is if there's an abbreviation that is not on our list, but it is something that is commonly and typically understood and used, you can use it. For instance, GBS. Okay, you do not have to write out group B streptococcal infection positive. You can put GBS even though GBS is not on that list. So the common sense ones, but I truly have seen really odd ones where I'll say, I'm not sure what you're trying to abbreviate here. And if I don't know, then that means it's not a common and typically used abbreviation. Maybe at your institution it is, but this is not something that's kind of across the United States, something that we would know. So please change that. For instance, abnormal uterine bleeding, they don't have that listed as AUB as an acceptable abbreviation. And I would say it's about 50-50 on the case list. A lot of people will put like AUB-L or AUB-P, and other people will spell it out. I don't really care. I don't mind if you spell it out if you don't have a whole bunch of other stuff in your in that column. But if there's a bunch of stuff in that column, then make it as short and make it as bullet point-ish as possible and go with the AUB. For instance, they have ASCUS as a pap smear, ASCUS, but they didn't list AGUS. Well, you do not have to, if you have an AGUS pap, you do not have to type out atypical glandular cells of undetermined significance. You can use AGUS. Do you know what I'm saying? So use common sense, but don't pick well, this is one too. I don't know why I didn't. NVOP for nausea and vomiting of pregnancy. I knew what it was, but I'm like, I don't know that I would use that one. That's kind of different than AGUS. So anyway, be consistent. This is another thing I find. I might look on, I'll be reviewing a case list and I'll say, look, I don't care how you want to list, let's talk about, say, induction of labor, because that's kind of an example. Within one page, they might say under treatment induction. The next one might say labor induction. The next one says induction of labor. The next one says IOL. The next one says labor induction with Pitocin. The next one says induction of labor with oxytocin. And I'm like, okay, any one of those terms are fine, but just pick one and stick with it. It just looks messy when you're calling the same thing 7 different things. Do you see what I'm saying? I want your case list to look clear, concise, consistent, well organized, well thought out. And then I've had same thing like with abbreviation. I had some people, they'll put GHTN, then the same person put GH, and I'm like, wait, but you treated it with blood pressure checking. So I guess you're not telling me genital herpes, it's gestational hypertension. Well, where's the TN to it? And then now you're spelling out gestational and then putting HTN. So I'm like, okay, don't use GH because that could be confused with genital herpes, but either use GHTN for all of them or gestational HTN, but don't flip and flop. And then again, we talked about, should you use caps and explanation points for unexpected findings? I don't think there's a right or a wrong. My preference would be not to do it. Dan says, I think you can do it. Shamra says, nah, I wouldn't do it. Just type it up professionally. And because to me, you know what this looks like to me, this caps and stuff, it reminds me of those cartoons, kapow, stuff like that. And I'm like, I don't want it to cheapen your case list, I guess. I just want it to be, this is what it is, this is what happened. And if they see that one, there's no reason to call attention to it. You're not trying to hide it, you're just typing it out like everybody else. But that's just how I would do it. If you guys like the kapow, put kapow. And you can blame Dan Green. I'm kidding. He and I are really good friends, which is why I can say that. Okay, GYN case list. So what are they going to look at here? So one of the main things they want to make sure of is that you are not an aggressive surgeon. And what I mean by that is when you're doing a hysterectomy for benign indications, they want to see that you have properly evaluated the patient, and that you have either offered her and she's failed it, or she's declined conservative management before you go to hysterectomy. That's really the main thing they want to do. So they're going to look at the, especially closely, they will look at young age hysterectomy. So anybody who you have on your case list who's less than 40, especially if they have low parity, make sure you feel really comfortable explaining to the examiner how you and the patient together with shared decision making came to the decision that doing a hysterectomy was what was in her best interest. And whenever I question the candidates, they've always got a good explanation. But you know, sometimes when you look on paper, like, wow, a 32-year-old G2P1, her uterus only weighed 112 grams. Why'd you do a hysterectomy? And the pathology wasn't really that abnormal. Well, maybe it was chronic pelvic pain and they'd exhausted everything. Who knows? But more of the times than not, when the candidate actually explains the whole story, everything they did along the way, the conversation, the counseling they had, and together they decided to do it, I'm like, oh, okay. You can explain that just fine to the examiner. I'm just telling you what it looks like on paper. I'm like, you did a hysterectomy on a 31-year-old with one kid and her uterus had one tiny fibroid on it. You see what I'm saying? So be prepared to the young age ones. Also, any hysterectomies that the pathology was basically normal, just be able to justify it. If you've got, the other big thing is the route of hysterectomy. So, you know, if you think about it from ACOG standpoint, you know, they wish every hysterectomy was a TVH. Well, just so you guys know, I'd say maybe 15% of the candidates have a TVH on their case list. The other 85%, the most minimally invasive they have is some sort of a laparoscopic approach. So it is not I'm always surprised when I see a TVH on the case list. So if you guys don't have one, don't freak out. You're in by far the majority. But what I want you to do is use that thought process as you're going through your case list to think, why wasn't this a TVH? And don't say, because I'm a way better laparoscopic surgeon than a vaginal surgeon. Have a reason. There was a pain component, or she's had a previous section, or there was poor uterine descensus, or there was concern for other additional pelvic pathology, or something like that. So at least kind of every hysterectomy you have, think through what you would tell the examiner of why you chose that route you did. Okay, low age and low parity. I'm sorry, go ahead.
What about the idea of a robotic versus straight
Yeah.
stick?
Yeah, and a lot.
I was in my hospital, which is residency. It was a private hospital with a new residency program, and so there was a big shift to everyone doing just robotic cases, and that's what we had most of our access to. So I'm, as a result, I'm more comfortable if I'm. I have TVHs, multiple TVHs in my case list, but when I do something laparoscopically, it's always robotic. Is that looked down upon?
No, it isn't, because it was until a couple of years ago, but there is a fair, and this, make sure you read this because you've got the robotics. It's a committee opinion, and it came out maybe last year or the year before. It's on the ACOG committee opinion. I'm pretty sure that's where it was. And it basically kind of retracts some of its negative statements about robotics. And it does talk about, there are some advantages to robotic surgery, of course, especially with obesity, but all that. But it talks about, it reduces or it eliminates tremor. You get increased 3D visualization, on and on and on. So read through that. And then I would say that at the hospital or how because see, as long as you've got some TVHs, you can say no. If I can do a TVH, I do a TVH.
Correct.
If this patient is going to need a different approach and I can't do TVH, and my choice is to do a laparoscopic assisted something, an abdominal surgery, or robotic, I go to robotic because these are the advantages I see in robotic. And don't just say, and you can say, and I've had extensive training with robotics. But in addition to your training, I would say these are the advantages that I see, that I experience with robotic versus the other. Now, the other thing too is so many people are obese now. You can always use the obesity thing. You know what I mean? That's part of it also. But if you read through that committee opinion, it really did talk a lot about advantages of robotic, and that's the first time ACOG has admitted that.
Excellent. Thank you.
All right, so what else? Okay, so if you've got any prolonged hospital stays, if you've got any complications, like you got into the bladder, the bowel, or something like that, and then what else do I have here? Be prepared to discuss conservative. Oh, yeah, because you might say failed medical management or declined medical management. Just be prepared to discuss. These were, if they said, well, so what medical management did you do? Just go over it. This is what we discussed. This is what she tried. This is what else I offered. She declined to leave an gestural IUD. None of that has to be written down, but be comfortable to discuss it. The other thing is, please be brief in your pathology description and don't list all the unnecessary items. Oh my gosh, on some of these hysterectomies, it'll be like chronic cervicitis, acute and chronic inflammation of I'm like, whoa, stop, okay? A proliferative endometrium with mixed progesterone effect. Okay, that is a benign endometrium. Yeah. Okay. So anyway, just and you don't have to say no atypia or malignancy. Guess what? If it was there, you would say it. So again, the only reason I'm saying this is, and Dan, I know went over this too, is the examiners already just been examining people all day long. They now got to look at 6 case lists. And the last thing we want them to do is be frustrated looking at your case list. With the OB case list, I used to talk about be careful if you have a really high primary C-section rate. I think the primary C-section rate is somewhere like in the 21, 22%. And then if you look at total C-section rate, because that's going to be the repeats, it's around 32, 33% nationwide. Well, now it's impossible then for them to know your C-section rate because you don't even list the vaginal delivery. So you might, if they ask you, hey, what's your primary and repeat C-section rate, just kind of know approximately what it is. If you have no VBACs whatsoever, be prepared to justify it. Maybe your hospital doesn't let you, because who was in the rural community? Are you allowed to do VBACs?
No, correct. I'm not. And there are a few instances I had no choice because the baby was about to deliver. But correct, I have to do repeat C-sections.
Yeah, but that's the thing. If you explain, this is where I practice, this is the policy here, then that makes total sense to them, and you don't even worry about it. What used to be, these are some of the stuff is historical. Calling something an elective induction or having a high induction rate, we used to think that was a problem, and we're like, don't say elective induction, give a reason, like the dad's going off to the Army. Now that the ARRIVE trial came out, we're like, heck, you can induce anybody once they get to 39 weeks. So our criticalness of induction has definitely, just don't worry about it. And you guys all know the ARRIVE trial, right?
Mm-hmm.
Okay,
Correct.
so I don't need to give a little summary of that. If you have a lot of 3rd and 4th degree perineal lacerations, that's kind of a quality measure. So they're going to look at that. So have an explanation for it. And then of course, with your postpartum hemorrhage and shoulder dystocia, not that it's a problem if you have a lot, but you need to know those emergencies inside and out. With the office case list, sometimes I still see a lot of old terminology used like menorrhagia, and we know they want us to say heavy menstrual bleeding versus that. They really don't. They'd prefer we don't say oligomenorrhea. They'd rather we say infrequent menses. Menometrorrhagia, they would prefer we get away from those terms. Then I see a lot of this, but that's because the pathologists are still listing it that way, I'm sure, like complex hyperplasia without atypia. Well, you guys know that's benign hyperplasia, right? So simple or complex without atypia is benign hyperplasia. Simple or complex with atypia is EIN. It's okay to list it as the pathologist has listed, but make sure that if they ask you about it, you acknowledge that that your pathologist is still using that terminology, but you are aware of what the proper terminology is and what you would call it. All right. Another thing I see is not enough follow-up visits. Like they'll say somebody comes in with abnormal vaginal discharge and they examine them, do the test, whatever, and they treat them. And then under results, they'll put symptoms have resolved. I'm like, but you saw them one time. So how do you know they got better? So have an answer for that. Maybe for vaginal discharge or UTIs, you tell everyone if your symptoms aren't completely gone in a week, please call the office and we will reevaluate you. So your assumption is they didn't call, they must be better. You know what I mean? Because that's the protocol you have set up. But I'll see ones like they'll start them on hormone therapy for vasomotor symptoms, and then they'll say symptoms resolved, but they saw them one time. I'm like, no, shouldn't you have maybe 2 office visits there? So just pay attention to that. Typos, oftentimes I'll find typos, but if you've already turned your case list in and you're reviewing it and you go, oh my God, I cannot believe I didn't spell that right, or can't believe I forgot to fill something out. It's okay, you already turned it in. Everybody's gonna have stuff on their case list that they find later. Who cares? But as long as you know about it ahead of time, then if they ask you, you're not going to turn beet red and get all flustered because you'll say, you can just acknowledge it. Yeah, yes, Yes, ma'am. Yes, sir. I did realize that after I had submitted it, I had spelled that incorrectly. I don't think they'll even say that, but if they did, you just know it and you move on. Know what's on your case list. Oh, you can choose the cases. Don't make them too complex. I'm going to show you guys an example uh, of an office case list that I reviewed. The candidate did excellent management on this patient. And it was an office case, and the patient had to come back 3 or 4 times. And really, really, the candidate showed how well they understood this disease process. But I was getting so frustrated trying to read this case and to try to follow the lines and to figure out what she did. And I was like, wait, dude, it's an office case list. Pick an easier vaginal discharge. Don't make one this crazy. So anyway, other things you should know is with regards to the OCPs you prescribe, know the type of progestin and the dose, or the type of progestin and the dose in it, and the dose of the ethinyl estradiol. And I know that sounds stupid, but we prescribe pills all the time. So know 2 or 3 of the most common that you prescribe and just know the dosing. Because if they said to you, oh, so that's what you prescribe the most, so what's the dose of estrogen in it? Ethinyl estradiol. I'd have to look that up. What's the dose? What type of progestin is in it? What's the dose? I can't remember. Oh, really? You prescribe that the most? You know what I'm saying. I just don't want you guys to get caught off guard. And then any medication that you put on your case list, it's fair game for them to ask you kind of a basic mechanism of action, like if you talk about letrozole or oxybutynin or something like that. You don't have to go into anything scientific, but you should know a sentence or two about it. What's the dose, the side effects, contraindications. All right, so again, okay, office case list. So what the heck goes in the result column? Is it the result of the diagnostic testing? Is it the result of your treatment? Is it the result of both? What do you put there? And again, it's a judgment call, but if you think about it, the examiner is reading your case from left to right. Patient comes in with complaints. Then you do your diagnostic testing, and you're going to list your diagnostic testing. I say put the results of that diagnostic testing in that column. Then the treatment is going to be based off that information in the diagnostic column. And then the results is, did your treatment work? Does that make sense? Because when I do I see it about a third and a third and a third. But if you put the results of your STI screen, so she comes in with vaginal discharge, and then you do in the diagnostic testing, you put STI testing. Then your treatment is azithromycin, safe sex counseling, etc. And then the results, positive chlamydia. Well, wait a minute. Now I'm having to go backwards, and then, but wait, where's your test for reinfection in 3 months? Then they don't even put that, because they just thought all they were supposed to put in the result column was the result of their diagnostic testing. So think about it from the terms of, why do they even make you do a case list? Patient comes in with a complaint. How are you going to evaluate it? How are you going to treat it? Did your treatment work? And if treatment A didn't work, did treatment B work? And if you think about it that way, it'll make a lot more sense. All right, so let's take a look at, go ahead.
In the office, multiple visits, and how do we make it seem like the treatments and results are not all in the first visit? Does that make sense? Meaning
Yeah. No, I totally see what you're saying. And it's kind of impossible to do that. So let's look at this one. Let me find another one here. These are some of let me see if I can find, because that's an OB case list. Let me find an office one. I'm gonna try to find something where they get a result later. Okay, let's look at patient 19 here. So here's a 21-year-old G0. Well, here's the one thing I said, okay, I know you put a G0, but for completeness, please put a 0 in the P category too, just so it looks proper. So STI screen 2 new unprotected sexual partners. Okay, so she did a pelvic exam, gonorrhea, chlamydia, trichomonas, vaginal swab, and then did this testing. So then if I go here, ceftriaxone, counseling, contraceptive counseling, desires pills, then I come over here and I go, wait, what? Gonorrhea positive, negative for chlamydia and trichomonas, blood testing negative, patient followed up for repeat STI screening, negative ×2, using condoms, no issues with OCPs. Now, can you see this is like a pain in the butt to try to figure out what they're even saying? Now, she did put 3 office visits, but so here's how I would have done this. So STI screen 2 new unprotected sexual partners. All right, so that's what she comes in with. So pelvic exam, the first thing, if I saw, this is where I would put, you don't have to put normal when it's normal, but if you saw something abnormal, list it. If somebody came in with dyspareunia and they were 63, I'd put pelvic exam dash vulvovaginal atrophy. Or here's, if this patient had, maybe she ended up with gonorrhea, maybe you could put dash mucopurulent cervicitis. And that's what the abnormal thing that you noticed. Then I would have put like either GC, or I probably would have put STI or gonorrhea, chlamydia. Well, I guess you could put it that way. I would put dash positive GC. And then I would have put the HIV, hepatitis, RPR negative. Now I know, and they know, you didn't know the gonorrhea was positive the day she came in, and that's all right. So basically what I would have done, because I was kind of busting her, I'm like, well, why did this lady get extensive? This lady only got counseling. So some people get better counseling than others. Just put safe sex counseling. That's going to cover everything. You can tell her about not partners and condom, just safe sex counseling. Then you could talk about the ceftriaxone, and you don't even have to say once, just say, and 250 milligrams IM. And I said, but no, the new recommendations now, it's 500 milligrams, but that's what you did at the time. Then you could put counseling on partner treatment or expedited partner therapy or whatever. And if you really want to put contraceptive counseling, desired OCPs, fine. Over here, the most I would have done would be, let's see here. I would put something like test for reinfection in 3 months negative, or just test for reinfection negative, and let them ask you when you did it, and patient satisfied with OCPs. And I wouldn't go into that she's using condoms now and all that kind of stuff. You could verbally talk about that. Do you see what I'm saying? And so sometimes, even though you're gonna, they know, like for instance, if you put mammogram as the diagnostic procedure and then it came back IRADS 3 and then you had to do additional stuff, that's gonna just be reflected in the number of office visits, but you don't have to line it up like, well, then she came back, then I gave her ceftriaxone on office visit number 2. That just tell the story as briefly as you can, and that's reflected in the number of visits. This is another example of where I said, oh my God, really? I just look at what I wrote on her thing. This is too complicated. So I think you guys can see, so she comes in, but this was good. Pelvic exam, profuse tenderness, erythema, and discharge with vaginal desquamation. And then she put suspected chemical burn from Monistat. So I guess she's saying this was my clinical impression. Okay, that's part of your diagnostic procedure. Then the vaginosis vaginitis swab collected, I wouldn't do that. I would just put, vaginitis swab dash positive trichomonas. And then, so then I started going, okay, so she treated then informed her of the STI, wait, then her symptoms resolved, wait, then her symptoms came back, but then she tested positive again, wait, then you counseled the partner ×2, what? And I'm like, just find somebody who had trichomonas one time and just leave it at that. So don't pick this complicated of a case. It's just not necessary. It's great management, and this is what happens a lot, but for the exam and for your case list, don't make it that complicated.
What about the idea of being word poor, so that way you can be asked a question? For example, when we're doing PCOS, instead of writing the fact that we got a total testosterone, 17-hydroxy.
I agree 100%. Here's a PCOS one. So here I said, here was my thing. She says 1 cycle every 1 to 2 years. I'm like, you know what? That's fine. You can leave that, or you can just say infrequent menses. And I thought, well, actually, you could even call it secondary amenorrhea, right? Because if you go 6 months without a period, if you have irregular cycles, that's secondary amenorrhea. So maybe secondary amenorrhea would have been a better term there. She had facial hair, acne, and then I wouldn't have said BMI of 43, because to me, this is more what the patient comes in with. I mean, you know she's obese. I would have put history and physical dash BMI 43, maybe just said facial hair noted or something, but you don't really have to because it's already here. Here she did say labs, and then she gave me the results over here. I would put for PCOS labs normal except testosterone elevated, A1C pre-diabetic, or I would actually just have said like A1C 6.0. You know what I mean? Something I would have given the results, because then they can ask you, so you told me what the abnormals were, but what other labs did you do? And
Okay,
then you can go through, and that I think is a great way to do it.
in mine, I wrote standard PCOS lab, so they can say, what do you mean by that? And I can go into it from there.
Perfect. Yep.
That's okay. I don't have to, because I didn't list any of that.
No, I don't like you to list all that stuff, because here's where I showed you right here. So here's patient number 20. Well, here's another example. Here's a patient, heavy menstrual cycles with severe dysmenorrhea. I said, I want this bullet pointed. I want on the first line, either heavy menses or heavy menstrual bleeding on the first line. Second line, capital S, severe dysmenorrhea. Bullet point it more, you know, and I don't mean you got to put a little hyphen by it, but you know what I'm saying? 2 different points, not making a sentence. So then this person, they did a history and physical. She's 15 and she says labs. That's fine. I might still say labs normal, you know, versus just labs. But then I go, wait a minute, but here's a 15-year-old with heavy menses. That's the one I'd really be thinking about. Could it be von Willebrand? I go, but here, patient 20, she's got the same thing, heavy menstrual bleeding and dysmenorrhea. And here you're listing CBC, hormone von Willebrand. No, just say labs. Do you see what I'm saying? Don't do this. And then I'm like, why are you doing this? Why is this one this and this like this? This is what I'm talking about, where it looks sometimes sloppy and inconsistent, because do you see what I'm saying?
Yeah, but now when I
About,
compare
yeah.
something like standard PCOS labs, do I have to put the ones that are abnormal underneath there, or just because I want to be
Well, you don't have to, but to me, I guess I would think most people might not remember what came back abnormal. They might not remember that this one had a normal A1C and that one was, her A1C was elevated, or this one did have a elevated total testosterone. So you don't have to list it. That would just be my recommendation, to list what the abnormal values were.
Right.
But don't list because, you know, for PCOS, what do you got to rule out all the, I mean, PCOS is partly a diagnosis of exclusion. If they come in with secondary amenorrhea, you still got to check a TSH or prolactin, a FSH, you know what I mean, pregnancy test, but don't list any of that. Just that's all the stuff that you checked that was normal.
Okay.
So Okay, so good. You guys, what other kind of questions do you have? Let me see. Oh, let me go back to some of the questions that candidates had. All right, so I had one other candidate said, what do I do for the patients who basically, she called them unregistered. She goes, they just show up in the ER and I got to deliver them. What do I put for their antenatal care? That's easy. In the antepartum column, you just put no prenatal care. And then you just discuss what you did. I mean, there's no other, that's just how you do it. She said, what do I do when I end up delivering a patient for another group because the doctor didn't make it to the hospital in time? I said, and she goes, I don't want to throw anyone under the bus. I'm like, oh, okay, so you just happened to be there, and they're like, doctor, and you're like, okay. And the lady did have all the proper prenatal care. So I said, well, I guess there's a couple of different ways you can do that. In the antenatal complication column, which it's not really a complication, but so you could either put it in the antenatal column or maybe just put it in the treatment column and just put prenatal care by another provider. And then in the middle column, the labor complication column where it says delivery and postpartum, you could put something like primary OBGYN unable to attend delivery, or you want to say missed delivery, but you know what I'm saying? Something that makes the fact that you just did the delivery and that's all you did. So that was one of the questions. What about with the MFM? So here's the big thing. They're like, what do we do when the MFM does most of the care? Like, you've got a patient, she has her inner antenatal complication, our incompetent cervix, and then the cerclage was placed, and they're following the patient, and they took the cerclage out, and basically all I did was the cerclage came out at 36 weeks, and now the patient presents in active labor at 39 and 2, and I deliver her. So how much do I put? So I said, you got some options here. Part of her antepartum complications was her incompetent cervix, so that's got to go in that column. In the treatment column, to line up with that, you could put like MFM consult or MFM managed or co-managed or something like that. Now, because she said, do I even have to list the cerclage in the treatment column if MFM did all of it? And that's where a judgment call comes in. If you just want to put incompetent cervix, MFM patient or MFM managed, whatever, and then labor at 39 weeks or actually you wouldn't even write that because that's not a complication. And then you basically just did an SVD. You could do that, or you could put in the treatment column, cerclage placed at 14 weeks by MFM, cerclage removed 36 weeks by MFM. But if you don't list that, that's all right. But be prepared to answer questions about incompetent cervix. So just because MFM management doesn't give you off the hooks from knowing about it, how do you diagnose it? What is history based? What is ultrasound based? What is rescue cerclage? When do you put a cerclage? When do you remove it? You know what I'm saying? So you can let them know that you didn't do it, but you still should be prepared to answer questions about it. Does that make sense?
The difference from OB to GYN, because I had a patient with twins who had a exposing bag, and it was like right at 19 and 6. I go back and see when we delivered, because she got choreo. If it's 20 and less, it goes under the GYN, and then 20 and 1 day and more goes under OB. Do we know what the
I would, you know what? I thought it all goes on the OB. That's all I've ever seen it. Even because they have second trimester losses and everything on the OB case list. I understand what you're saying of what it's considered, but I think for the boards or the case list, I'd put if they're pregnant, unless it's a missed AB, that's going to, and you're doing a DNC, that's going to go on your GYN. But if it's, oh man, Like, that's a good judgment call. I think I'd still put it on OB. What about the rest of you? Where would you put it? She comes in with the incompetent cervix, bulging membrane. She's less than 20 weeks. I'd put that under the second trimester loss on the OB one.
Yeah,
I would probably
will
put that on
it
OB.
in OB.
All right.
And yeah, so again, it's judgment call, but that's where I would put it too. So I guess that we did a nice vote there. Okay, so here's another question. So the patient said, okay, I did surgery on the patient and she had omental adhesions to the anterior abdominal wall. Do I list that in the complication column, or do I just list it in the surgical pathology column? Like when I say I took down adhesions and if I wanted to list that. So I'm going to say, you know what? This is again a judgment call. If those adhesions were significant and you couldn't even get into her abdomen, you had to call in a general surgeon or GYN onc to help you, then in the treatment column where you were doing your surgery, I would list, either general surgery consult or GYN onc consult. And if the adhesions were that significant, I'd put those over in that complication column. Extensive pelvic adhesions requiring GYN assist or general surgery assistance. But if you took down the adhesions and they were there and all it did was make your life more difficult, I don't think I would list that as a complication. I might list in the surgical pathology column if I felt I needed to, in addition to my lysis of adhesions under the treatment. You could say something like extensive omental adhesions or something like that. Does that make sense? But either way is okay. This is where some of the judgment stuff comes in. Think about, I want to make this crystal clear to the examiner what happened. Does that make sense? All right. So then, here's the other one. So there was one of the candidates says, okay, I was in fellowship training and the attending did not do a pre-op endometrial biopsy before doing a robotic assisted hysterectomy for abnormal bleeding failed medical therapy. How do I address that? Because on her case list, there's nothing that says about EMB benign. So I said, okay, if you're asked about this case, you can explain the situation and say, I was in fellowship training. This was the blah, 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 I did it. This was the attending's patient. But take control of the conversation. So anytime there's something that you were in fellowship or you were in something and you would not have done it that way, jump right in and say, well, this patient was a patient of my attending, but had I been the patient's primary physician, this is the pre-op evaluation I would have done on her, and I would have done an EMB prior to. You're not throwing anyone over the bus. You're telling why the situation was as it was, but then just jump right in and take ownership and say, now, had I been the patient's primary physician, this is the way I would have done it. And I think that's a nice way to do it. And you're not throwing anybody under the bus, but you are letting them know you would have done it differently. And then remember, it's impossible to be clear about every case you have. I guarantee you 99% of the time when I have, I'm like, I don't know what you're trying to tell me here. Or I'm like, oh, why did you take out the ovary of a 19-year-old with a corpus luteum cyst on it? You know what I mean? But when they explain to me what actually happened, and maybe it was torced and hemorrhagic and gushing blood and all that kind of stuff, I'm like, oh, okay, well, that's not the picture I got looking at the three little things you put on the case list. But almost always when the candidates explain to me what happened, it makes sense. And so if you ever get asked about certain things, don't let something shake you up. Just be prepared to discuss it. All right, so let me just see here. I mean, I know we've gone way past, but do you guys have any other? Oh, let's look at the OB case list for a second, just for how is it structured. Antepartum. I want you to think about this as problems that you take care of in the office and what their diagnosis was on admission. So that would be your preterm labor, PROM, etc. This middle column, and see, these are supposed to be complications. A lot of times people will put labor. Okay, I'm like, labor at 40 and 3 is not a complication. You'd kind of like want that to happen. So then think about this. I wish this said labor, delivery, or postpartum, because here's where I want, and even this doesn't make sense. Why would you put choreo here, but then have the category 2 tracing over here? I mean, unless when she was admitted, she had it just doesn't make any sense. Anyway, so you're going to put in this column chorioamnionitis, category 2 FHR, maybe the brow presentation, and second stage arrest, which doesn't even make any sense to me. The brow had to, if she got to the second stage, but whatever. Anyway, and make sure, but this stuff should go in this column. The next thing to think about is when you list stuff here and here, it's got to be addressed in here. So, and again, I've double checked with Shamroth multiple times. I'm like, okay, so they can't just say anxiety or depression or asthma and not address it in the treatment column. He goes, that's right. Either don't put it if you don't think it was a big deal. Just because somebody has mild intermittent asthma, who cares? You don't have to list it unless it made some big difference. If she had mild anxiety and you didn't do anything about it, she wasn't on med, she didn't go see a counselor, well, don't even list it then. I mean, it wasn't a significant part of her OB care. So do you see what I'm trying to say? You know, the stuff that's important, list. And if you do want to list it, then at least put, you know, albuterol inhaler PRN or something like that. All right, so another, but make sure it lines up. Don't do it like, oh, this maybe isn't a great one, but there's certain ones, people might list 17 things, I swear to God here, 17 things here, but they're not even in the same order. And I'm taking lines and then, okay, so that goes up there. And I've got this mess of lines trying to figure out what was going on. As best as you can, try to be like advanced maternal age, you know, declined NIPT, all right, fine. Then maybe you would put next RH negative. That's really all that should be here. She could put RhoGAM there because I get it at 28 weeks, right? So you could put RhoGAM there. Then you go over here, and then whatever came next, if she wants to list intrauterine resuscitation next, then I'd probably put the category 2 FHR because that's going to line up better with that. Then I'd put maybe my choreo, then that's going to line up with the antibiotics. Then I would put my second stage arrest because that kind of goes with the CD. Do you see how that's going to just make it a little bit easier for the examiner?
Sure.
All right. Go ahead.
For gestational age, that's the age on admission or when we delivered?
Great question. And they never, ever, ever clarify that. I would put it the gestational age on admission. So think about like this is their G, because here's another thing. I have a lot of people who they'll put a 39-year-old G1P1 at 39 and 2. And I'm like, okay, she can't really be a 1-1. She's either a 1-0 or a 2-1 because this is like goes along with this admission here. Think about we're kind of telling the story like this. So let's say somebody got admitted at 32 and 1 with PROM, okay? So then she was admitted, and then you'd have your latency antibiotics and all that kind of stuff. Then you would put down here PTL at 34 weeks or something like that. Or you could put over here, if she was induced at you could put induction at 34W. But this would go along with when she got admitted. And you guys know if your 5-minute APGAR is 5 or less, you need to put a 10-minute APGAR. So that would go in this complication thing. You just would write 10-minute APGAR and you'd put that right there. Any more questions? I know we've gone way over, guys. Didn't mean to. We're about 20 minutes past. But
can we email you a
any
question? Do you have
any questions for me?
No, so far.
All right, so that hopefully that makes sense. But the most important thing is, like this one, I think looks pretty nice. I mean, they did AUBL. She's telling me what the ultrasound shows. Here's what the endometrial biopsy shows. Probably the only thing I would say, instead of putting history of laparotomy and going right into here with failed, I'd put failed underneath. You know what I'm saying? Because then it's line, 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 line. But to me, this looks pretty nice, neat. Here's her complications, readmitted for post-op ileus. Here she even talks about she ended up having to convert for laparoscopy to abdominal, but she did say history of a midline vertical abdominal incision. So she's even kind of shown, hey, this is probably why this happened. But I think this looks pretty nice. She doesn't go into all kinds of crazy pathology and stuff like this. I'm with Dan. I probably wouldn't put 242.4 rounded up or down. They don't really care about whatever fraction of a gram, but stuff like that. So good. All right. Well, I'll be back with you guys, I think August 2nd, and I think we're just doing some structured cases. So anyway, hope that was helpful, and thank you guys for hanging in there, and good luck with your case list construction.
Thank you.
Thank you.
Thank you.
All right, bye-bye.